All right, good morning, everyone. It's my pleasure to moderate the session alongside Dr. Atala, who is online. Unfortunately, he had clinical duties to attend to, so he'll probably join us for some questions at the end. And we'll also have a chance, I think, after all three speakers to be able to go through some questions people have. And also Paul's here, who's going to be moderating as well. So the first speaker that I have the distinct privilege of introducing is Dr. Jeff Haroldson. He's the Executive Director of Medical Affairs for Tenaya Therapeutics. Jeff has over 20 years of experience in the biotech industry, with the majority of his focus on rare diseases to help bring precision medicines to patients to address a significant unmet need for the currently available therapeutic options of these individuals and their families. So, Dr. Haroldson, we're happy to have you, and I think it's wonderful that we finally get to talk in this area of medicine about more than just beta blockers and ICDs, because that's been quite inadequate for many people for many, many years. So I think it's super exciting to be able to talk about potentially curing these diseases before they even have their phenotypic onset. So thanks.
Great, thank you so much. And it's an honor to be here. Thank you for inviting me. We're happy to be sponsoring this meeting as well. And on behalf of all my colleagues at Tenaya Therapeutics, who work very hard every day to get to where we are. So a really exciting time with gene therapies for cardiomyopathies. So I assume most of you, I know some of you know Tenaya Therapeutics, but I imagine most of you don't. So I'm going to do a brief introduction of who we are, what we're working on, and I'm really going to focus on our two lead gene therapy programs, and that's TN-201, which is our gene therapy for MYBPC3 associated HCM, and then our TN-401 gene therapy program for PKP2 associated ARVC. So who are we? I mean, we really are grounded in patients first. It's our number one core value at the organization. We have a phenomenal patient advocacy team who actually brings patients and their families into the organization frequently and through webinars. So even for those who don't have a healthcare background in the organization, they've really learned what the burden of disease is like, what it's like to live with the disease, and what the hope is in terms of unmet need and therapeutics. So it really drives our purpose in terms of developing molecules, gene therapies for rare diseases, and trying to bring potentially curative therapies to these patients and families. So I'm going to introduce the company. There's a lot going on here, but I'm just going to emphasize a couple of things. Number one, Tenaya Therapeutics is singularly focused on the heart. So in all of our preclinical programs, including our 3 clinical stage programs, it's all cardiovascular disease, mostly focused on rare cardiovascular disease with a genetic cause of the disease, but we do also target some more prevalent cardiovascular diseases. As such, our leadership, we have several cardiologists who work at Tenaya. We also have gene therapy experts, experts who have been worked in rare disease for years, and we really feel like that's a really terrific union and collaboration internally to really drive this forward. We have on the bottom left, or actually that just popped up, 100 plus employees. We're a small but mighty company, a little over 100 employees. Tenaya is based out of South San Francisco. And also on the bottom right of this slide, I think, which is important in developing genetic medicines, we invested in developing our own manufacturing facility to really have control over product purity, safety, quality, and that's really essential, we believe, in terms of delivering safe and effective gene therapies for patients. Not sure how intimately aware of everyone in the room is with gene therapy, but I'm going to focus just on AAV gene therapy. It's really relatively new in the cardiac arena. Our HCM program is out ahead of our PKP2 program, and that has been a pretty big learning that I've discovered in talking with HCM experts. And so AAV went from being discovered in a lab in the mid-1960s to now well over 20 years of experience. You can see that over 5,000 patients have been dosed worldwide. The majority of those have actually been in a rare neuromuscular disease with a product called Zolgensma for spinal muscular atrophy. At least in the US, we have 8 FDA-approved products now, gene therapy, AAV-driven gene therapy products, and really good follow-up, more than 15 years of follow-up in certain disease areas such as hemophilia. When you look at clinicaltrials.gov across the globe, there are over 200 AAV gene therapy trials underway across the globe. You can see the majority are in the U.S. and elsewhere. And on the bottom right, just to put it in perspective, about a dozen of those now are focused in cardiovascular disease and cardiomyopathies, and you're going to hear about a few of those today. So just to dig in to our very first program, it's the TN-201 program. We're calling the trial My Peak. So Tenaya is a mountain range in the Yosemite area in California. So we have very cute titles for our trials, all related to climbing mountains, peaks, and ridges. So we have, so our first TN-201 is targeting specifically individuals with HCM with mutations in the MYBPC3 gene. So we know that in HCM, roughly almost 60% of all cases of HCM are driven by genetic mutations, and of those, the MYBPC3 gene is the most common. ClinVar, actually in a recent report, put out that out of all HCM variants, almost half of the pathogenic and likely pathogenic variants in HCM are in the MYBPC3 gene. So that gene encodes cardiac myosin-binding protein C, which is a really integral component in the thick filament primarily, that thinking of it simply as like a braking mechanism. So when that protein content is low, and we know from surgical myectomies in adults with HCM studying protein content, that protein content is about 60% of normal. So it is reduced. You see the phenotype as a result of that, and without that protein on board, that you see the hypertrophy, relaxation time delayed, diastolic dysfunction, all the sorts of things that we see in HCM. So we really believe that bringing a transgene to the cardiomyocytes to help restore near normal levels of protein should restore cardiac function. Jason already went over this. I would say my illustration maybe is a little more interesting probably with colors, but the idea here is you take the AAV, we use AAV9 serotype. There are several AAV serotypes. Different serotypes have different tropisms in terms of targeting different tissue. AAV9 is very well established in targeting cardiac tissue. Essentially, the viral DNA is removed, and then a full copy sequence of the transgene of interest, in this case MYBPC3, is inserted, along with other cargo, regulatory elements, the promoter to help the gene initiate transcription, and so forth. This is delivered intravenously over a couple of hours infusion. It's a one-time administration, as Jason mentioned. And again, the AAV9 vector is really, really effective at targeting cardiomyocytes, undergoes uncoating, and again, forms episomal DNA, does not integrate, and restores cardiac myosin-binding protein and leads to restoration of function. The TN-401 program, we also use AAV9, so I just want to pause on this slide and just at least give you the rationale in terms of why did we select AAV9. Number one, it's very well established in the market as far as efficacy and safety data. Most of that, again, is in young children with SMA, but also Duchenne muscular dystrophy has used the AAV9 vector quite substantially now, too. Novartis has just recently reported up to 8 years follow-up now on these SMA patients. So we really know what you're getting into as far as efficacy, know what safety signals to look for. Currently, it's only capsid with validation in human hearts with patients receiving gene therapy with the ability to transduce cardiomyocytes and leading to durable gene expression. And we'll hear from Dr. Schwartz, I'm sure, on some of that data with the Danon disease. And then also, it's the most extensive body of clinical evidence, preclinical evidence, and independent studies in the PKP2 disease model. And we just recently, at the ASGCT conference in May, published and put together some of our own data where we actually really wanted to dive into this a little deeper, looking at AAV9 versus other capsids as far as transduction and expression. And we found that AAV9 leads to higher expression. And we really feel that that's important because with AAVs, even though they are less immunogenic than adenovirus, we still see these complications and potential risks. So with higher expression, we're able to come in at lower doses, and we certainly hope that that translates into a better safety profile for patients. One slide on the TO1 preclinical data that helps inform and shape the dose going into the clinical trial. These are some key efficacy readouts that we looked at after we looked at the 3e to the 13, so 3 times 10 to the vector genomes per kilogram. Much different way of thinking in terms of how you deliver these therapies with a dose in the MYBPC3 knockout mouse model. And you can see from moving from left to right, the black is the wild type, blue is the control animal not treated, and then the 3 orange bars. We had different doses, and that middle orange bar is our 3 to the 13, so where we saw near maximal efficacy in terms of reducing LV mass, and the middle bar, those animals actually saw an increase in ejection fraction and then stabilized over the duration of the trial. The study in the blue bar, you can see that the ejection fraction continued to rapidly decline. A lot of these benefits led to 100% survival in these animals treated with TN-201. It's overlaid on top of the wild type, or the lighter color across the top on the right. 100% survival to the point of sacrificing the animals at 18 months, whereas you see all the animals, the control animals who were not treated, did die shortly after a year. So brings us now to our trial, the MyPeak phase 1b trial. We have initiated dosing in patients, and the first patient was dosed in the fall of last year. This is, as the 1b in gene therapy trials, this is primarily a safety trial. We're looking at safety, tolerability. This is still the dose finding with the opportunity to, with the data safety monitoring board, based on findings, efficacy, safety signals, we may move into a slightly higher dose, so that's to be determined. Right now, we are starting this trial in adults with non-obstructive HCM. Got to be symptomatic, and an ICD present at this point, and EF's higher than 50%. The neutralizing antibody titers are important. That's part of the eligibility criteria. This is an open label design, so all patients entering this trial will receive the gene therapy. There's no placebo control at this point. And you can see the schematic in terms of looking at 2 different dosing cohorts with the option to continue dose expansion up to a total of maybe around 15 patients through the phase 1b cohort. Some of the outcomes that we're looking at are endpoints, again, safety and tolerability. A lot of the usual suspects, for those of you who are familiar with the HCM trials with the cardiac myosin inhibitors, looking at all the structural and hemodynamic changes, exercise capacity, KCCQ score. But of course, the one thing that's different here is we want to make sure we'll be doing biopsies in these patients to ensure transduction and expression. It's a 52-week study, but then it's followed up with a 4-year follow-up with much less frequent assessments. Here's where we are currently across the United States with clinical trial sites. We are not currently in Canada, but we have several leading cardiomyopathy centers involved in the U.S., and even despite that, we know that trials like this are going to demand travel within or even outside of the United States. So our clinical development and clinical operation teams are fully prepared for that sort of situation. So jumping to our second program, that's in the TN-401 program. This trial is called RIDGE-1, and this is looking specifically at the PKP2 population, where you all know almost 40% of all cases is driven by a mutation in PKP2. A significant unmet need. You know this disease, but a lot of these patients present with sudden cardiac death and a lot of anxiety around ICD therapies and so forth. So again, I think a really important patient population where there's a significant unmet need. In our preclinical models, again, a dose ranging study. I think I have some things to fill in here. Yes. So just looking at, again, some key efficacy parameters, we are also bringing in the same starting dose at this level based on preclinical studies, moving from, again, left to right, that 3E13, again, near maximal efficacy in terms of reducing arrhythmic burden, improving ejection fraction in the mouse model, and then also reducing RV enlargement. The AAV9 dose that we found with this near maximal efficacy is where we achieved transduction at about 1 vector genomes per diploid genome. So the biopsy, the tissue in these animals, of course, it's all mushed together. So you're getting different cardiac tissue. Roughly half are cardiomyocytes, half are non-cardiomyocytes. But on average, this roughly equates to about 1 copy per cardiomyocyte. And so similarly to the TN-201 program, again, the IND was cleared at the early part of this year. So we are now moving into that phase where we will be dosing our very first patient in the second half of this year. So very exciting time again for gene therapies in the PKP2 population. Again, safety and efficacy, we're looking at adults again to start out this trial, symptomatic adults, looking at least a baseline PVC count of 500, keeping the EFs above 50% at this point, and NYH classes between 1 and 3. And again, open label. So all patients entering the trial will receive the gene therapy. So looking at a lot of safety signals, changes in PVCs, non-sustained VTAC, frequency of shocks, VTs, all sorts of biomarkers, and patient-reported outcomes. We have a few different quality of life assessments that we're using in this trial as well. Not as many active states. Again, we are not in Canada, so my apologies, but we could talk to Jason and Dr. Crown about this. But again, so this is where we are, and we're committed also to bringing this program to Europe and probably initiating in the United Kingdom as well. So, but this is where we are now. We've done a lot of work here to get where we are, so we're super excited about this.
At this point, I'd like to invite Dr. Jonathan Schwartz on behalf of Rocket Pharmaceuticals. Dr. Schwartz has spent the past 25 years developing scientifically based targeted therapies to more safely and effectively address deadly diseases. He's a founding officer of Rocket Pharma, where he has advanced gene therapies for hematologic and cardiovascular disorders during the past 8 years. Welcome.
Thank you. Good morning. It's a pleasure to be here. Canada, people are friendly. Coffee is bitter, but that's better than the reverse. So over the next few minutes, I'm going to spend a bit of time discussing the Rocket Pharma sponsored gene therapy programs in Danon disease, PKP2 ARVC, and time permitting, a little bit about BAG3 dilated cardiomyopathy. Let's start with Danon disease, which is an X-linked disorder that results in impaired autophagy. Mutations in LAMP2 prevent adequate lysosomal autophagosomal fusion, which is essential for autophagy, which is the way cells digest and get rid of unwanted material, senescent proteins, damaged mitochondria, etc. And when autophagy is deficient, all that material builds up in autophagic vacuoles, which create a lot of disarray in the myocardium. And this results in a very profound and aggressive cardiomyopathy. Specifically in males, this usually results in a very extremely hypertrophic and rapidly progressive cardiomyopathy with median survival around age 19 or 20. Median survival for females is approximately 2 decades longer, but there's a great deal of variability. There are also extracardiac manifestations such as skeletal myopathy, although those tend to be less severe and not generally life-threatening. Our phase 1 study was conducted over recent years and involved RP-A501, which is an AAV9 containing full-length LAMP2B gene. Patients were eligible if they were male. We started with those who were at the highest risk for progression and adverse outcomes. Patients were excluded if they had high titers of neutralizing antibodies against AAV9 prior transplant. And during the study, prior to the pediatric cohort, we also implemented an eligibility criteria requiring preserved left ventricular ejection fraction. More on that momentarily. We treated 3 cohorts of patients, starting with the cohort 1, which is the low-dose adult cohort. That's a bit of a misnomer because that cohort was age 15 and above, and even though it's a low dose of 6.7 times 10 to the 13 genome copies per kilogram, that's still a lot of vector that's being infused into human beings. So it's low only relative to the other dose. That was the first cohort treated, and therefore we have the longest follow-up out to 36 months as of about a year ago. We also treated 2 patients in the higher dose adult cohort. That's not a dose that we're continuing. And we have follow-up now out to 24 months in that cohort. And then 2 pediatric patients who were both around age 12, who also received that 6.7 times 10 to the 13 dose, with follow-up now out to 1 year or more. Very importantly, of these 7 patients, 6 are followed up long-term and have derived benefit. The one patient, patient 1007 in the adult high-dose cohort, had more advanced disease and had progressive cardiomyopathy, required a transplant after about 6 months. So we'll present safety from all of the patients and efficacy from the 6 of the 7 that did derive benefit. This is a table that illustrates some of the baseline characteristics of the patients. As you can appreciate, the adult cohort patients were all between age 17 and 21 at study entry, and the 2 pediatric cohort patients in the bottom rows were around age 12. All patients were symptomatic with NYHA class 2 heart failure, and all patients had preserved left ventricular ejection fraction, except for patient 1007, who had diminished LVEF, likely indicative of more extensive fibrosis, which is why we believe that patient was not able to derive benefit from the therapy. As illustrated in the red boxes over in the right portions of the slide, these patients had extremely hypertrophic hearts at baseline, with just for the non-cardiologists in the audience, the typical upper limit of normal for LV mass is around 225 grams. Everybody in this study had more than that, including the kids who were part of the trial. Several of the patients had very high BNP at baseline. All of the patients had elevations in troponin, with the lowest elevation in high sensitivity troponin I being 7 times the upper limit of normal, indicative of the cardiac injury that's ongoing in this disorder. And we'll talk a little bit about the safety before going into efficacy. And this graphic illustrates the evolution of the immunomodulatory regimen that we utilize to try to prevent problematic immune responses in the days and weeks after vector administration. So in the first low-dose adult cohort, we started off just using corticosteroids at a relatively high dose, 1 mg per kg of prednisone, and then gave some sporadic tacrolimus based on hepatic enzyme values. In the second high-dose adult cohort with the 2 patients, we gave the same steroid dose but also used tacrolimus preemptively, as well as 2 doses of rituximab. Importantly, within those 2 adult cohorts, we did have 3 patients that had a steroid exacerbation of the underlying Danon disease skeletal myopathy, resulting in grade 3 muscle weakness. And fortunately, that resolved with a taper of steroids and supportive care, and fully resolved as these patients continued to be followed over the long term, but was something we sought to avoid going forward. We also had one patient in the high-dose adult cohort who had a grade 4 complement-mediated thrombotic microangiopathy, which resulted in high-grade renal failure and thrombocytopenia. Fortunately, those resolved as well over the course of a couple of weeks and completely resolved. But again, that's the sort of complication that we seek to avoid going forward. So for the pediatric cohort, we adopted the immunomodulatory regimen of a lower dose of corticosteroids, about half of the dose in the prior cohorts, 0.5 mg per kg, with an earlier taper starting around day 10, sirolimus instead of tacrolimus, and rituximab. And the sirolimus and rituximab are intended to provide more synergistic B-cell inhibition to prevent antibody-antigen complexes, which trigger the classical complement pathway. And as a result of that, we did not have any substantial myopathy in the pediatric cohort, and we also didn't see evidence of substantive complement activation. Platelet count, which tends to be the very best bellwether for complement-mediated TMA, where those platelets remained in the normal range. Very importantly, with this regimen, beyond the 2 patients that were treated in our Danon pediatric study, we published an analysis of 15 patients receiving this same sirolimus rituximab lower dose steroid regimen. This included patients at University of Florida and NIH with GM1 gangliosidosis and SMA1. This was in the January Journal of Clinical Investigation. And one can appreciate across whether you're looking at the immunoglobulin graphs at the top, platelet count and D-dimer in the middle, or some of the complement moieties, including activated terminal complement C5b9 complex on the lower right, that the complement activation in the red group, getting rituximab and sirolimus, was markedly lower than in patients who were just getting corticosteroids. And that's the regimen that we'll carry forward in the phase 2 study, as well as in the ARVC trial. So we'll turn to efficacy now, and this is a representative cardiac biopsy of one of the pediatric patients. In the top row, you can appreciate that in the months and not represented years after therapy, there is expression of the LAMP2 protein fairly diffusely in the myocardium, and that expression is accompanied by a reduction in the autophagic vacuoles, those empty-looking holes that you can see in the middle row on the H&E slides, or on the lower rows in the electron microscopy. And that reduction in these vacuoles is quantifiable, and I think you can appreciate, especially on the month 6 images in the middle and lower right, that a lot of the myofibrillar architecture appears much less disarrayed, much more normalized relative to where these patients were at baseline. In addition to seeing improvements in the myocardium, we saw improvements across a broad range of clinical parameters. So the troponins, which were all markedly elevated, were reduced quite remarkably. The BNP, which was at times elevated, reduced in those situations. And for patients who were normal or near normal at baseline, they remained relatively stable. The lighter green indicates stability. The darker green indicates improvement. Red indicates worsening. There's no red on the slide. The parameters of cardiac hypertrophy, such as left ventricular mass or maximum wall thickness, also reduced quite remarkably. Patients reported far fewer symptoms. The majority of patients at most recent follow-up were asymptomatic NYHA class 1 with fairly demonstrable improvements on the Kansas City Quality of Life score. A KCCQ improvement of about 5 points is considered clinically meaningful. We were able to demonstrate that in several patients, and improvements of 15 or 20 points in several others. This is just a graphic illustration, a little easier to read, of several of the patients with respect to left ventricular mass index, where you can appreciate that LV mass continues to normalize in the months and years after therapy, that's something that we'll continue to track out to 5 or so years post-therapy. This is a graph also of the BNP. You can appreciate the phase 1 trial results for BNP on the left panel, where the patients who had marked elevations for the most part normalized, patients who were normal range remained there, and that's in contrast to what we saw on a prospective natural history study, where you can appreciate over anywhere from 3 to 30 months in Danon male patients of a similar age, these BNP levels continue to typically increase, in some cases very dramatically. So we were able to show the favorable safety profile for the low dose 6.7 with an appropriate immunomodulatory regimen. There were improvement across multiple parameters in 6 of the appropriately selected patients, and by and large continued signs of improvement or stabilization with ongoing follow-up, and we hope to provide further data updates for this phase 1 study potentially later in this year. And this resulted in our in agreement with FDA for a single-arm pivotal phase 2 study that is underway currently at centers in the United States and soon to be in Europe. This will enroll 12 patients, single-arm open-label trial using the 6.7 10E13 dose. The primary endpoints of this study will be assessed at 1 year and include LAMP2 protein expression in the myocardium, as well as an at least 10% reduction in left ventricular mass index. There are obviously multiple secondary endpoints that we'll continue to track, including quality of life. So moving to a topic that's most highly germane to this audience is PKP2 ACM or ARVC. And I really don't have anything to teach anyone in this room about this disorder. But we have come to recognize that this is obviously a disorder that affects people often in young adulthood. And despite a lot of advances in the field that were discussed and really very nicely elucidated this morning, we're still talking about a significant health burden, significant mortality risk, and particular subgroups of individuals based on ARVC risk calculations who may have a very high probability of ICD shock or other sudden death events over the course of 1 or 2 years, 3 or 5 years, and obviously a lot of things that potentially could be improved upon. RP-A601 is an AAV RH74, which is a variant that's very closely related to RH10. It looks like we have a MAC PC incompatibility issue with some of the graphics on this slide, and it's my fault for not QCing that early this morning. But at any rate, what I'll emphasize is that we did develop a number of animal models with an induced PKP2 knockout in mice, and we were able to show really tremendous survival advantage, improvement in left ventricular ejection fraction, improvement in right ventricular dilation at clinically applicable doses, and very importantly, this was done in mouse models in which the investigational vector was given after the induction of the knockout, in some cases 7 or 14 days afterwards, and which benefit was shown despite that. And very importantly, we were able to markedly diminish the incidence of isoproterenol-induced arrhythmias as demonstrated in the lower right, where you can see a lot of ventricular ectopy in the untreated mice and a nice sinus rhythm in the treated mouse cohort. The phase 1 study for RP-A601 is underway currently, enrolling at UCSD and University of Pennsylvania. This is encoding a full wild-type PKP2A gene. We evaluated multiple AAV serotypes in the preclinical studies, and we went forward with the AAV RH74 construct that is a RPA601 because it had the most favorable safety and efficacy in relevant disease models across a range of doses. And really seemed like the most appropriate one to carry forward specifically for this disorder. AAVRH74 has been associated with a favorable safety profile at high doses in Duchenne muscular dystrophy, as evidenced by the experience with the Sarepta approved gene therapy product. And we felt that it really was the logical choice. The study initial dose is 8 times 10 to the 13 genome copies per kilogram, which is a dose that we believe, based on the animal models, really confers a reasonable probability of clinical improvement. We continue to utilize the immunomodulatory regimen that I described, including rituximab, sirolimus, and lower dose steroids, to minimize potential for complement activation and other immune-mediated effects. For patients who are enrolled, this is daily monitoring in the hospital for the first 1 to 2 weeks with subsequent outpatient follow-up. The last program that we hope to bring to clinic over the coming year is in BAG3 dilated cardiomyopathy. BAG3 is a really complex and diverse protein that influences a large range of myocardial functions, from contractility to apoptosis to protein quality control. This is another disorder that frequently onsets in young adulthood, although sometimes even in adolescence or childhood. There's, for patients who progress to dilated cardiomyopathy, there's a 25 to 30% 5-year event rate with significant mortality over 3 to 5 years. Hopefully more on that program as we get closer to clinic. Preclinical studies are underway. A tiny bit about Rocket Pharma. The 4 clinical programs that we have presented data for, all of them are really ushering in a new era of genetic medicine. Two programs will potentially be approved this year for use in the United States, and that's in leukocyte adhesion deficiency 1, which is a devastating early childhood immunodeficiency, and Fanconi anemia, which is a bone marrow failure syndrome. 2 other programs are now in registrational trials with FDA and EMA alignment, and that includes red cell pyruvate kinase deficiency and Danon disease. Hopefully PKP2 will be next. The Danon disease results really represent the first gene therapy for a highly aggressive cardiomyopathy. We have multiple patient testimonials regarding gene therapy's effect on their lives. One of them is illustrated on the middle right portion of the slide. There are many others that are available on our website or elsewhere, and the same is true also for the other programs in the hematologic disorders. I think we found that our work in the immunology and hematology gene therapy has really informed a lot of the cardiovascular gene therapy efforts. It's really an additive process. Rocket has, I think, a track record of dedication to patient safety. We collaborate with investigators around the world to try to continue to optimize the safety regimens that are utilized. We are relentless advocates for research and support in rare and high unmet need disorders. On Rare Disease Day, February 28th or 29th, buildings around the world light up in rare disease colors. It started with our corporate headquarters at Empire State, and now it's everywhere, the Colosseum in Rome, and all sorts of other structures. It matters to us. Obviously, all of this happens because of a tremendous amount of collaboration with colleagues at institutions all over the world. Several of them, those institutions and many of those colleagues are illustrated here, including Barry Greenberg and Joe Rossano, who've been really critical partners, and Barry Byrne at University of Florida, many people on the Rocket team, and of course, the patients and families who've been really tremendous partners and advocates in good times and bad. So thank you for your attention.
Great. Thanks so much to both of you for the incredible presentations on your current projects. I think we probably, according to Jason, only have just a couple minutes for questions because we're running impressively behind. But maybe just if the speakers can keep their responses to maybe 30 seconds, we'll have time for 2 or 3 questions. So I'll open up with a question if anybody else wants to ask anything. I'm sure that they'd be open to answering just about anything from the basic stuff to the very complex stuff. So my question is, in cardiomyopathy, you frequently develop, end-stage disease that becomes irreversible, which is quite a bit different than people with ion channelopathies, where you don't get a bunch of fibrosis and scar. And I just always wonder a bit about these cardiomyopathy gene therapies and the timing of intervention and reversal of the disease. And I see it much more as a condition that maybe is better reversed in the early stages. So if you can maybe both provide a 30-second response to that in terms of your plans and thoughts on inclusion in studies.
Sure. I think you summarized it very well. There's a Thai proverb. It's much easier to help an elephant that is getting up off the ground than stop one that's about to fall into the ground. We think that really across a large range of disorders, the goal is to try to get the right gene into the right group of cells before there's irreparable damage. And I think our Danon experience emphasizes that once you have decompensation, extensive fibrosis, even the most well-constructed targeted therapy is not going to be able to rescue that situation. Early diagnosis makes a great deal of difference in many of these diseases. And I think, fortunately, we are one of many academic and biopharma groups that are really advocating to enable more accurate early diagnosis. So many patients end up seeing multiple clinicians and caregivers before a correct diagnosis is made. That's true regardless of the genetic disease, and that's something that we can change. I think that's something that is changing.
I think that captures it all. I mean, that is the tricky spot here at gene therapies with patients, is when to initiate. I agree with what Dr. Schwartz said. I don't know if I had much to add. I think it's the fibrosis and the scar. You're not reversing. In our animal models, we dosed with once they had overt cardiomyopathy, or we treated before they had an onset of disease. In both those cases, we would see some reversal, but it comes to a certain point.
I have a very basic question, but maybe a little bit unfair. I'm just wondering, how confident are you in long-term expression of those genes once they're in there?
I'll take a stab at it. I mean, we know from other therapeutic areas, as I mentioned, we have efficacy out to, several years, over 15 years. I think the advantage in targeting cardiomyocytes, non-dividing cells after about 1 month of age, really gives us a strong position for durability of effect. Dr. Schwartz demonstrated some efficacy out to 3 years in that initial cohort. So I personally am feeling pretty confident about the durability, but I'll let Dr. Schwartz add to it.
Yeah, well, certainly the cardiomyocytes are the heart is a good organ to target with AAV, because even though there's non-integration of the genes, that epigenetic or episomal transduction is likely to last. Most cardiomyocytes, by and large, are not dividing after about 1 month of age. So whether you're treating adults or children, I think there's a very good prospect of long-term benefit. And we continue to see increasing evidence in the hemophilia world for the longevity of benefit with most, if not all, of the programs. In fact, just last week in Blood, one of the major hematology journal, there was a really nice update from a multi-country group with now 12 years of follow-up in a hemophilia dog model, showing that the durability of hemophilia therapy, and that's in the liver. And we know that liver cells do divide much more so than heart cells, so that gives us a lot of cause for optimism.
Great, thanks. And I think Dr. James, our keynote speaker, has a question. Maybe a comment is better in terms of timing, but yes.
I have actually a very simple and fast question. We've talked to a lot of patients about gene therapy trials on the horizon. The phase 1 trials are appropriately small and appropriately have relatively low-risk patients, but are complex and obviously risky. Our patients have a lot of uncertainty about whether or not to participate. Can I just ask very clearly, how is enrollment going in your HCM and ARVC phase 1 trials? It's different, right, than for Danon disease, where the course is going to be bad.
Great, thanks. And this will be our last question, so hopefully we can keep our responses quick.
We haven't started our first patient dose in PKP2, so that's that question answer. And we've screened. We did a phase 0 seroprevalence study in our HCM cohort, where we enrolled over 100 patients just to get antibody titers outside of the screening window. So there's a lot of enthusiasm. These trials are rigorous, and so I think with the hospitalization requirement, If these patients have jobs and children, it's very demanding in the first probably 3 to 6 months. So it does make it more challenging. We are going to release some data at the end of this year, so I can't spoil that news. But it is more challenging, I think, because of the rigor of the clinical trials.
That's very well stated, and I can state that for the PKP2 ARVC study, enrollment is happening. We'll provide more granular updates potentially later this year or soon thereafter. Because of SEC requirements and all sorts of other stuff that I'd rather not even mention here. I can't really provide the things. You don't want me to go to jail for insider trading, because that will make enrollment that much more difficult. More on that during lunch.
I'm just happy to hear the answer isn't 0.
Great, thanks everyone. We'll move on to the next session.